Good evening and welcome to tonight's Men's Health webinar with Dr. Majdee Islam. Tonight, we'll have the pleasure of hearing from a fellowship-trained urologist who will tell us all about the signs, symptoms, and treatment options for erectile dysfunction. You have the opportunity to interact with him, so you can ask questions anytime during the presentation. Simply tap on your mobile device, move the mouse on your laptop or desktop. A toolbar will pop up. Click on the chat button, type your question in, hit submit, and we will address those questions during or after the presentation. Without further delay, I'd like to introduce Dr. Islam.
Well, good evening. I appreciate you all joining me for this talk. And kind of like Mike mentioned with the introduction, the talk is going to be a talk about men's health, specifically about signs, symptoms, and treatment options for erectile dysfunction. So without further ado, we'll get started. The first thing that I've got, there we go, is basically this survey. So if you're interested potentially, either now or potentially at the end of the talk, you can pull your phone out, open the camera, hover over this little code, and then a survey will pop up that we actually use in clinic quite a bit about erectile function, potentially signs and symptoms. You can kind of see what personally what your score is at, what your symptom score is at, and potentially how severe erectile function you may be having and how much it might be affecting your life. So this is an important tool that we use that you can use as well. A little bit about me, though. I'm at the Urology of St. Louis group here in St. Louis. I have offices at Fairview Heights and St. Peters, and also in Town and Country pretty soon here as well. I was born and raised here. I went to med school at Mizzou, and then I did undergrad there as well. Residency in Colorado. I did my fellowship at UCLA, and I did a men's health fellowship. So I specialize really in basically men's health diagnoses, things like low testosterone and hormone management, erectile dysfunction, as well as sexual dysfunction overall, infertility in men, Peyronie's disease or penile curvature, and then male prostate health as well. And so, erectile dysfunction, the important thing about it is basically the definition, I think, which is, I think it's interesting that, a lot of guys, when they think about erectile dysfunction, think it's potentially an issue with being able to get an erection, period. When importantly, it's actually, in my opinion, and in most opinions, the inability to get an erection that's satisfactory to a man's desires or sexual needs, essentially. So the inability to get an erection that's potentially rigid enough for intercourse is the main definition. But what I think is important about erectile dysfunction, for every guy, it can be a little bit different in that you can have a man that's getting erections, but that's not having erections that are rigid enough for intercourse or that are lasting long enough or maintaining during intercourse, and that's considered erectile dysfunction as well. And there's things that we can do to help those guys along with the guys that aren't able to have an erection. And in terms of how common it is, about 20% of guys in general are going to have some aspect of erectile dysfunction. Half of guys over 40 years old have some aspect of erectile dysfunction, but then also on top of that, about 40% of men under 40 actually have some aspect of erectile dysfunction. So it's actually quite a bit more common than guys think. And you can see almost 40 million men have erectile dysfunction or some aspect of it. And so, obviously with erectile dysfunction, the issue is a blood flow issue. And you can kind of see from a flaccid state to an erect state, the idea of getting an erection. But, kind of going a little bit more into it from an erectile function standpoint, the pathophysiology, you get aroused, stimulation, etc. The nerves around the penis get activated, and then you have these smooth muscles that are in the penile blood vessel, the penile vasculature, that start to relax, and that's what causes blood flow to get into the penis. So you've got this flaccid penis on the left side, and on the right side, you can see those blood vessels are nice and open. The smooth muscle within them are relaxed, and that's how you get an erection. In that you get blood flow that goes into the penis. These smooth muscles are nice and elastic, so they stretch pretty well, as well as the tissue around them. Then the arteries open up, and there's these veins that are around those arteries that get compressed. So then you get blood flow that's going into the penis. That blood is staying in the penis and not leaving the penis, so then you get an erection. And then the issue oftentimes ends up being, as we go to this next page, with that picture being a little bit bigger, the issue ends up being keeping that blood in the penis, along with potentially getting that blood there versus having stimulation of those nerves. And those are kind of the issues with getting an erection. And then, the things that can cause that to happen, the risk factors, the top three are vascular, diabetes and medication. So vascular kind of encompasses things like high blood pressure, high cholesterol, things that are causing a guy not to be able to have as much blood flow in the penis, because over time with those things like high blood pressure, high cholesterol, you get this essentially plaque buildup or narrowing constriction of the arteries all over the body, the penis being one of the smaller arteries. And so that's oftentimes what's affected first. It can also be an effective prostate cancer treatment, whether that's radiation or the surgery or getting your prostate removed, as well as things, other things that are a little bit less known, neurologic issues, pelvic surgery, et cetera. The other important thing there is that's kind of at the bottom there, erectile dysfunction. It can have a pretty broad negative impact on health related quality of life. So quality of life is super important with erectile dysfunction, not only because you're not able to get an erection, but also from a mental and psychological standpoint. It can really affect guys and get in their heads, but it can also affect relationships. It can cause stress at work. It really can affect a guy throughout their entire kind of life and being, essentially. And so I think that's a really important part of erectile dysfunction is the psychological aspect, as well as the stigma behind erectile dysfunction, in that it's difficult to talk about. Once a guy has erectile dysfunction, it's something that's embarrassing. You don't really want to talk to your buddies about it, much less bring it up to your primary care physician or your doctor in general. But also that oftentimes in a relationship, it's tough to talk about because A, it's embarrassing, but B, sometimes a spouse can think that you're no longer attracted to them, and there's something that they're doing wrong, and it can be something that can put a lot of strain on relationships, which I think is important. So delving a little bit further on the risk factors, so diabetes is a big one. Quite a few people, 15 million people in the US have diabetes. The important thing about diabetes, and I'll breeze through this, but this is pretty important, is that to have an effect from erectile dysfunction medication, things like Cialis, Viagra, et cetera. A lot of these guys have to take a higher dose of it to be able to get an appropriate response. And usually in men with diabetes, their erectile dysfunction ends up being more severe. And then the other really important thing is erectile dysfunction is a symptom. It's not actually a disease. And what I mean by that is erectile dysfunction isn't something that happens by itself. There's something that's going on that causes a guy to have erectile dysfunction. Diabetes is one of these big things. And kind of like in that slide that I showed before, there's something that causes the erectile dysfunction to come about. And a lot of times, erectile dysfunction is one of the first things that a guy will find that they have before they find out that they've got things like diabetes, high blood pressure, high cholesterol, et cetera. And so I think one of the important things is when a guy has erectile dysfunction, A, to get treated, but B, to go visit a primary care physician, to visit someone that's going to be able to do a workup to make sure that you've got those things all lined up, and potentially to treat those things, high blood pressure, high cholesterol, diabetes, et cetera. So I think that's an extremely important part of this talk, is making sure that we all understand that it's not only erectile dysfunction that's the issue, but it's the other things that are potentially causing it. And so kind of going through this with diabetes, the things that it affects is not only the things that we talked about back at the beginning of the talk, blood flow, that's the issue, as well as nerve function. Diabetes actually affects both of those. It can decrease the amount of blood flow because it damages the artery, but it also can it can damage those nerves. And so that's how diabetes causes erectile dysfunction. And, the erectile dysfunction medication, basically, the idea is to try and help bring in blood flow to the penis and to stimulate those nerves. But if you're having issues with the artery having damage and the nerves being stimulated with the diabetes, the pills won't be as effective in those patients. That's important to potentially know. And so, there's factors including, age, how long you've had diabetes, how bad the diabetes is, et cetera, that can affect men and cause it to be a worse form of erectile dysfunction. And then moving on, heart disease is pretty similar. So, what I mean by that is heart disease also can cause erectile dysfunction because in and of itself, with having heart disease, you've got a decrease in blood flow to certain parts of the body, which include the heart itself, but also the penis. And so erectile dysfunction in a lot of studies has been shown that it's an independent risk factor for future heart-related events. And that's important to note, in that if a guy has erectile dysfunction, again, it's important to get a workup on things that are potentially causing this, which includes a heart disease. And so making sure you see a primary care physician or potentially a cardiologist to ensure that you're getting your workup for potentially having an event that may be pretty drastically affecting your life in the future. And so Uh, this fact always baffles a lot of patients, but erectile dysfunction can precede heart disease by a few years, which is important again because the erectile dysfunction arteries are so small that they're first affected oftentimes prior to having symptoms from heart disease like chest pain or trouble climbing stairs, etc. So again, an important factor to note is, you know, you can have erectile dysfunction, but then have something else going on. It's important to get that figured out or get that looked at. Um, you can kind of see here again, the reason is because the artery is so much smaller than, let's say, your heart arteries or your carotid arteries, which are the neck arteries, or the femoral, which is in your leg. And so again, the penile artery is going to be affected long before some of these other arteries are going to be affected. Reducing the risk of erectile dysfunction. Again, the important thing about with heart disease and or diabetes is you can improve your erectile dysfunction just by getting your heart disease or getting your diabetes or your hypertension, or your cholesterol, etc., treated. So lifestyle things like diet, exercise, not smoking, reducing stress, the things that are going to help with the diabetes and help with heart disease are also going to help with erectile dysfunction as well. I want to talk about testosterone just for a second, and not delve into too much. But testosterone and erectile dysfunction go hand in hand. When a guy has low testosterone, it affects their erectile function. It can decrease the ability to be able to get a good, nice, rigid erection. Quite a few men can have a low testosterone. About 40% of guys over age of 45 have testosterone, and it's more common in men that are diabetic, men that have high blood pressure, men that are obese. Basically, a lot of the risk factors for erectile dysfunction are also risk factors for low testosterone. So oftentimes in my patients, when they come in to see me for erectile dysfunction, one of the first things that I do is check their testosterone levels along with other hormone tests. And so it's an important thing to note that it's something that we should check for, and it's something that can be pretty easily treated along with the medications for erectile dysfunction. You can treat a guy for low testosterone with things like gels, injections, oral medications, etc. So that's a pretty important thing to note. And then finally, I wanted to talk about prostate cancer. As with erectile dysfunction, it's pretty it's not uncommon. It's a common complication or side effect potentially of prostate cancer treatment. So the nerves that control erectile function are they run right next to the prostate, as you can see in this picture. And so whenever you have prostate surgery, the prostatectomy, what we're trying to do as urologists, we try and basically move the nerves out of the way as long as they don't have any signs of cancer in them, to take the prostate out and leave those nerves intact. However, just by touching those nerves, you can potentially cause the guy to have their erectile function take a hit. It can take sometimes up to a year to a year and a half even to see improvements or the return of the erectile function. However, some guys, despite complete nerve sparing, can have their erectile function not necessarily come back fully. And so that's important to note that despite a perfect surgery, you can still have your erectile function affected. Upwards of even 30 to 50% of men can have some aspect of erectile dysfunction after prostate surgery. And so you can kind of see here, you're cutting the prostate out and those nerves are running right next to the prostate. And that's why it's so important to note that you can have some issues with erectile dysfunction afterwards, but there's potentially treatment options. You can kind of see here, quite a few guys have an issue with erectile dysfunction after the surgery, and 50% of guys or more have issues with sexual dysfunction, erectile dysfunction after radiation of the prostate as well, after prostate cancer. So then Peyronie's disease. So I do quite a bit of Peyronie's disease as well. And Peyronie's disease is basically when you have penile curvature. You've potentially seen those carrot commercials on TV about having a curvature with an erection. Usually happens after some kind of an injury to the penis, whether a guy knows it or not. And there's treatment options that you can have with Peyronie's disease, because what happens is there's this scar tissue that forms. You can see that plaque at the top part of the penis that causes that erectile tissue, that stretchy tissue, not to be able to stretch as much in one spot anymore. So then you get curvature. And the way we basically treat it, the most common treatment that I do is Xiaflex, which is an injection into that plaque area to basically dissolve the plaque. You can also do a couple of surgeries where we either remove the plaque or I place a couple of stitches to straighten the penis out. But the important thing about Peyronie's disease and erectile dysfunction is they can go hand in hand, because when a guy's not having an erection that's fully rigid, it's a little bit more bendable. And then whenever you're trying to have intercourse with a penis, it's not as rigid, it's more likely to bend. And potentially during intercourse, when it pops out and potentially you're trying to go back into the orifice, it can bend pretty good and cause you to have a decent amount of trauma to the penis, where then it can cause scar buildup and and have a plaque, and so you can get curvature. So Peyronie's disease, erectile dysfunction and Peyronie's disease kind of go hand in hand, because then with Peyronie's disease, when you've got curvature, the entire penis isn't able to expand as well. So you've got this vicious cycle of erectile dysfunction and Peyronie's disease, which then begs for potentially more erectile dysfunction. Oftentimes if a guy has both erectile dysfunction and Peyronie's disease, and we've gone down the road of what to do for erectile function treatment, you can place an implant in that can potentially fix both things at the same time. And so this kind of talks about what we just talked about in terms of that curvature. I'm sorry, for erectile dysfunction, for Peyronie's disease. Moving on after that, there's treatment options for erectile dysfunction. But one side that's really important is there's certain treatment options that I'm potentially, I'm sure that a lot of guys have heard of because they're pretty well advertised, which includes shockwave therapy, as well as stem cells and platelet-rich plasma, which is PRP. These are pretty experimental, so they're investigational. There are some studies that are coming out, especially for the shockwave, that are somewhat promising, but insurance usually doesn't cover them, and a lot of times you're paying quite a bit of money to have these treatment options that you may or may not be a candidate for. So I strongly recommend, especially if you're thinking about doing shockwave, to see a urologist before you go through trying to do something like this. The stem cell and the PRP is extremely experimental. We still don't have a whole lot of data. There's not really any urologists that are doing that. The shockwave therapy, some urologists are doing it. Actually, I do the shockwave therapy as well, but there's a very small subset of patients that I do it for that potentially has the option. I apologize, a little bit of a technical difficulty here. Let me get my screen back. Apologies.
Did you lose control?
I did, and I should be able to get it back here momentarily, I think. It won't let me resume share. I'm so sorry. Give me just a minute.
Says you're sharing.
Can you see my screen, Mike?
I cannot. Do you know if you're sharing your entire screen or just a window?
Oh, it says screen sharing pause, and then I can't hit resume share. I apologize. Let me try leaving and coming back. I apologize. 1 second. I apologize. Mike, are you able to see my screen now?
So just said you started sharing your screen. Do you know, so there's two options. You can share a window or you can share your entire screen.
I'm so sorry. It says my screen sharing is paused and it won't allow me to reshare the screen. That's unbelievably frustrating.
Man.
Give me just another minute. I'm sorry, folks. Let me try logging out one more time. And I've stopped sharing. Is that correct, Mike?
Just try it one more time right now.
Yeah, share screen. Clicking on the browser that I want to share. Just one. Share. And it says my screen sharing is paused.
Mike, could you share your screen?
Oh, how about now?
There we go. Yep.
I'm so sorry. That's terrible. Okay. I appreciate you guys for your patience. Okay, so the idea of this slide, I apologize for that, is basically make sure that I would strongly suggest you see a urologist prior to doing any of these treatments to make sure you get some advice about potentially moving forward with it. Okay, so this is kind of the meat of the talk here. So treatment options for erectile dysfunction. there's a nice wide variety of erectile dysfunction treatments that range from things that are pretty conservative and move on to things that are a little bit more aggressive and invasive. So it starts with oral medication, so things that you've probably heard of, Cialis, Viagra, etc. Then I'm going to move over to the vacuum erection device, which is basically a glorified penile pump, essentially, that you place over the penis. There's urethral suppositories, there's injections, and then all the way up to a penile implant. And I'll talk about these a little bit in more detail here coming up. So the medications, basically the idea is they bring in blood flow to the penis by allowing the smooth muscle to relax that we talked about, allowing those arteries to expand. They're quite effective. They work about 70 to 80% of the time. Viagra in particular can be affected by food intake, which is important to note. There's side effects that are pretty mild, but there's some guys that are, that are affected quite a bit by, the Cialis or the Viagra, which can include, facial flushing, sometimes a little sinus headache, a bit of acid reflux, things of that nature. And the other important thing is if you're taking a nitrate medication, we always look out for that to make sure that you don't have a potential side effect by that. But otherwise, it does pretty well. Most guys tolerate it pretty well. This is always kind of my first go-to option. What most anybody's first go-to option should be in terms of taking the medication. You can either take it daily, or you can take it as needed about an hour before intercourse, and it works pretty well for most guys. But oftentimes, over time, they lose their effectiveness because potentially guys are either you're getting a little bit more fibrosis in the penis, and so you're not able to get as much dilation, or over time it just stops working as well because you're potentially you're having progression of the disease process, whatever that may be, that's causing the erectile function issues. And so next, we're jumping, a little bit ahead, but the ICI, the intracavitous injection therapy, basically this is usually a little bit further down the road of options, but I usually try either the vacuum erection device and or a suppository first, which we'll talk about in a second before doing this. But basically, the injection therapy, the medication is a liquid version kind of what's in the Viagra and the Cialis, but it's a more concentrated version along with a couple other medications. The idea of most of those medications, the medications are to help dilate the artery and the penis, but by putting it in a liquid form and then injecting it directly into the side of the penis, you're injecting it essentially into that into the blood vessels themselves of the penis. And so it works pretty well in men. There's pretty good success rates because of how highly concentrated it is and because you're putting it straight into the penis. The issue with the medication is A, it's a needle that you're putting into the side of the penis, but B, some guys have about 10% of guys will have this kind of ache or pain with the erections. And overall, to be totally honest, it's not the most comfortable thing in the world. The problem with with the ICI over time is that it can be a little bit cumbersome to draw up the needle with the medication in the vial, and it can cause you to get to a point where a lot of guys just get fed up with using a needle to get an erection, and it's cumbersome. It's not the most romantic thing in the world, but it's usually kind of the last ditch effort that we'll do with a lot of my patients before we jump to something that's more invasive like surgery. I do have a lot of patients that have been doing the injection therapy for years and have no issues with it, and they have great results. And so, there are a lot of guys that use it well, and have great results from it. And so, we alluded to the vacuum erection device. This is oftentimes what I'll use, kind of in combination with the Cialis or the Viagra. And basically, the idea is it's kind of a glorified penis pump. So you place a cylinder on top of the penis that's got the suction. You start the suction, it pulls blood flow into the penis, and you put a little ring at the bottom of the penis. And the idea is it brings blood flow into the penis and allows you to keep that blood flow in there. It works pretty well. Again, about 70%, 80% of guys have good results from it. The only problem is it's pretty cumbersome. You can oftentimes have a little bit of potentially bruising or decreased sensation with their orgasm or with their sexual function. And also there's a little bit of a decrease in, you can almost get this cold penis type situation. And so it works in in a lot of guys that are on the Cialis, but need a little bit more help essentially. But again, it can be cumbersome. It can be a little bit uncomfortable. And so a lot, I would say I have a very small percentage of guys that are doing the vacuum erection device that have been doing it for a long time and enjoy doing it, I guess I should say. So then The suppository. So this is something called Muse, and there's two versions of it. There's a pill and there's a liquid form now, actually. But the idea is taking the essentially what's in again the Cialis Viagra medication, making either a pill form or a liquid form, and then placing it intraurethral or into the end of the penis. Success rates are a little bit lower, and anecdotally, in my practice, they're actually probably a little bit lower than the 40 to 66%. There are some guys that do have some pretty good success with the medication, with the Muse, with the suppository, but it's a little bit uncomfortable to place into the urethra because you're placing something that usually you're not putting something into. There can be a little bit of bleeding with it, and also there can be a little bit of urethral burning or pain with the medication placing it in there. So again, it's one of those things where it's a little bit more invasive. There are some guys that I have that have some success and use it. To be totally honest, for the most part, most guys don't use this for an extended period of time. At least in my experience so far. And I think, for the guys that do use it, they use it for a short amount of time and then move on to something that's a little bit more potentially invasive, but more effective. And there's a question in the chat, in terms of using medications and using them for years, a lot of guys will use the oral medications and have a great response to them for a certain amount of time. But the issue is kind of like I mentioned before, sometimes some guys just have an issue with being able to continue the medication, to have the medication be as effective as it used to be. And sometimes that can be from progression of whatever disease process that was causing the erectile dysfunction. But a lot of times you have an issue with maintaining the erection. And kind of the question ends up being, if you're having good success with the Cialis and getting an erection but not maintaining, what potentially you could do. And there's a couple options. Sometimes you can increase the dose of the Cialis. You can potentially take a daily dose of Cialis and have that be a little bit, basically what the Cialis ends up doing is it decreases the fibrosis or scar tissue formation on the smooth muscle layer of the penis. And so by taking Cialis daily and adding that onto an as needed dose of Cialis, it can help with the maintenance of the erection as well. Or there's actually a supplement that oftentimes I'll have guys take. It's called citrulline. It's L-citrulline, Citrulline. And that's something that increases nitric oxide in the penis as well that can potentially help with the maintenance of the erection. And so those are some options that I have, along with potentially moving on to something that's a little bit more invasive or aggressive in that treatment option therapy. The last thing sometimes you can do is potentially try another medication. So try Viagra, try other medications called Stender to see if that's more potentially effective or that helps with the maintenance aspect. So then moving on to the penile implant. So basically the penile implant is kind of the last thing that we would do, the last ditch effort. And that's the end of the road. Usually with my guys that are deciding to do a penile implant, they've either tried almost all of those therapies that we just mentioned, or they tried some of them and they couldn't wrap their heads around placing a needle into the penis, which is very understandable, and decided that they wanted something that's going to be it. That's the end of the road, and this is going to be something that they have for hopefully quite a long time without having to deal with the fuss of an injection or deal with the fuss of always taking a bunch of medications or the suppository. How it works: there's a pump that's in the scrotum that sits basically between your testicles at the bottom of the scrotum. There's these cylinders that go into the penis, and then there's a reservoir that goes behind the pubic bone. I do all this through a little incision that's about 4 or 5 centimeters in the scrotum, and I place all the hardware in there. But basically, you take that pump between the testicles, you pump it up about 15 to 20 times or so. It takes you about 30 seconds. You get completely rigid. You use the erection, and then once you're done, there's a little button that's on top of that pump that you hold for about 3 seconds. You give the penis a gentle squeeze, and then you lose the erection. You get rid of it. As simple as that. The important things about the implant, you don't lose any sensation. So the penile sensation stays intact. You don't lose your ability to orgasm. So if you were orgasming before getting the implant, you're going to continue to be able to have orgasms. And then most importantly, you can use the erection as long as you need to. And then once you're done, you just press that button. And so, there's some guys that will continue to use it to help their partners out even after they've orgasmed, because you can, which is great. It's 95 to 98% effective. Once the implant goes in, it lasts for quite a long time. And most guys that come back and we've done studies on this that say they had great results from being able to have the implant. And usually it's because it's been 10, 15, 20 years since they've been able to have an erection on demand, and now all of a sudden they're able to. Now it's a surgery. So, the important thing is, any kind of surgery has these risks that are involved. And whenever you're placing an implant, into a body, meaning a foreign object that's going in the body, there's some risks that are involved. The most important one is infection. I always tell every guy there's going to be a risk of infection, especially if you're a guy that's diabetic. And so it's important to get your diabetes under control. But we do a lot of things before, during, and after the surgery to reduce that risk of infection. There can also be some bruising, some swelling, a little bit of discomfort in the scrotum that usually resolves over time. But then there can also, the device can malfunction or be malpositioned. And so then sometimes, rarely, but sometimes we have to go back in, usually, later rather than sooner, to either reposition the device or potentially take it out and put a new one in. So we kind of talked about the effectiveness and how it works. There's three different main types of devices. The most common one is that one on the left, the three-piece penile implant. That's basically the one we just talked about. There's a two-piece implant, and we don't use that one super, at least I don't use it super often, but basically that doesn't have that reservoir aspect that goes in the abdomen. You basically, to get an erection, you use the pump, and then to get rid of the erection, you press that button. But the idea basically is you don't have a reservoir that's in place. It's a little bit, I don't use it as much basically because the implant doesn't get as deflated as the three-piece as well. And so you can see or feel the implant a little bit more. And then the malleable is the one on the very right. That's basically where you just have the cylinders and that's it. It's called a semi-rigid implant because it's always a little bit, rigid. It's almost like having a pipe cleaner in the penis. You can bend the penis upwards, use it whenever you need to. And when you're done, you fold it down and that's it. And usually I only use that in guys that don't have great hand dexterity, that aren't going to be able to use that pump very well. The most important thing about the implant, any kind of prosthetic device has a risk of infection. And with this implant, there's basically an antibiotic treatment that's basically within the device itself. So when you place it into the body, it's got this antibiotic treatment that's already on there. It's called inhibizone. But basically, I don't know if I'm allowed to say that, but basically with that inhibizone, it's got antibiotic, it's minocycline and rifampin that's in it that allows, or at least it decreases the risk of infection of bacteria to be able to stick to that implant. So it reduces the risk of that infection. But most importantly, with the specific type of material that they're using Boston uses for the implant, it's designed to be the closest to be able to have a natural erection, and it feels like having a real erection. And then when it's deflated, even more importantly, it looks like a regular deflated penis, which is important as well. To a lot of guys, because a lot of guys don't want other people to know that they've got the device in place. And so let's see, I'll see if this plays. It's about a minute video about basically how the implant works. So I'll give it a second. So you can see down here, you've got that pump that's at the bottom of the scrotum. That pump is then, by pressing it, it's taking fluid from the reservoir in the abdomen, going into the cylinders. You pump it up, you get a nice rigid erection. So now you've got the erection, it's pointing straight out. And once you're done, you press this button that's on top of the pump. The fluid goes right back up into that reservoir that gives you that deflated penis. Okay, so just a couple quick things about the procedure itself. Usually, it's an outpatient procedure. I usually have patients go home afterwards. It takes me about an hour and a half to do the procedure itself. Sometimes if you've got, heart disease or other comorbidities, I'll have you hang out in the hospital for one night just to make sure from an anesthesia standpoint that you do okay. I do the incision again through a little opening that's in the scrotum. It's about 4 to 5 centimeters. And if you've had other surgeries in the past, sometimes I'll do a separate incision to place that reservoir in that's right above, basically above the pubic bone. But both those incisions are about 4 to 5 centimeters, and that's about it. Usually I have guys that take it easy for about a week or so before going back to, light activity. And then for about 3 or 4 weeks, I have to take it easy in terms of any major physical activity. And then about a month to 6 weeks before going back to sexual activity to make sure everything heals up perfectly. And then the important thing to note, and then there's a question in the chat about this, but usually usually the implant is covered by insurance. So even with Medicare, the implant is almost always covered by most, private insurances and Medicare as well. And so I very rarely have any issues from an insurance coverage standpoint. Mostly it's just paying the deductible and making sure that's covered in straight away. But then after that, it's pretty smooth sailing. I actually have I haven't had very very many issues with getting guys covered by insurance. So, again, we talked about the benefits. It's proven it works. There's a great satisfaction rate. It's covered by insurance. It lasts for about an average of about 15 years, actually, but sometimes upwards of 20 to 25 years. And it looks nice and natural. We talked about the risks in terms of infection, mechanical failure, some discomfort afterwards. And again, the big important thing is that risk of infection. So I always tell guys, this is a surgery. It's a fantastic surgery, but it's a surgery. So there's risks involved, which includes infection. So making sure that guys understand that risk and understand that it is a surgery, there's a recovery period, but ideally after that recovery process, it's the results are excellent. And most guys are unbelievably satisfied and happy. And so, I wanted to end by basically saying that erectile dysfunction, it's a really common problem, like we talked about at the beginning. There's a wide gambit of options to treat you. And, there's a lot of guys that have great success at each level, whether that's the medications, whether it's a suppository, the injections, or the implants. And I think it's important to have a conversation with your urologist, whoever that may be, to talk about what the options are for you. And if you're a candidate for the treatment options, what you can do. I'm happy to answer any questions. However, we do have the luxury of having Cliff Pollock, who's one of our patients that it's actually, I'll let Mike introduce him a little bit more, but that's actually, that's going to talk to us about his experience with having the implant. I'll stop sharing my screen here. And I apologize for the issues beforehand about that. And we'll let Cliff come on, or I guess Mike talk about Cliff.
Yeah, it's my pleasure to introduce Cliff Pollock, who is New York native, but has been in St. Louis for most of his adult life. He's going to talk about his journey with prostate cancer and addressing some of the side effects after.
Hello, good evening, everyone. Mike, can you hear me? Hopefully you can.
Can hear you well, yep.
Okay, thank you. Like Mike said, what you're going to hear is the journey that I and my wife took from the time I was diagnosed with prostate cancer through dealing with ED and then finally conquering it. One thing I think is very important right off the bat is just to let you know, ED is not just a male problem, it's a couples issue. And the sooner you get your couple, your partner involved with you, the easier it is for her or him to understand what's going on. And like the doctor said, a lot of times people call me and say, my wife thinks I'm having an affair with somebody else. They don't think I love him anymore. And that's the farthest from the truth. So based on that, I basically, when I was 58, was diagnosed with prostate cancer. I decided after talking with the urologist that the best thing to do was to remove the prostate. After my prostate was removed, I went back to the doctor. I went back to, excuse me, my regular doctor. And I said, look, I'm not getting erections. This was about 6 months afterwards. And he said, well, let's try some pills. So they put me on Viagra. Unfortunately, I was one of those people that had bad reaction to Viagra and then to all the other pills. I got headaches that were so bad, I just couldn't pick my head up off the pillow. And never in my life did I think I would ever tell my wife, not tonight, honey, I have a headache. But that's how it was. They were terrible. From that, I went back to my doctor and he gave me the idea of the external vacuum device. Now that did work. However, there are some things that are not very cool about it. Number one, it is not very spontaneous. You have to stop what you're doing and you have to pump up. Well, it always seemed to me the more excited I was, the longer it took to pump up and get that little band on the base of the penis. People call it a band, I call it a tourniquet. It does hurt when you take it off. It comes up the shaft well, but once you take it over the head, it hurts. I used that for about 4 months and gave it up. At that point, I went back to my doctor and he said, I don't know what else to tell you. So I just left. And for 2 years, nothing was done. I had nothing done. I didn't know anything about anything. And finally, this is way before COVID. When I was 61, I got an email letter from a urologist, a prosthetic urologist who happened to be in the same office as the urologist who did my original prostate surgery, and he invited me to a talk on ED. And there's where I found out about the little suppositories called Muse, the injections, and the excuse me, the inflatable penile prosthesis. After speaking with my wife, we both made an appointment with the doctor. We spoke for 45 minutes to him and asked if I was a candidate for the implant. The answer was yes. The day after my 61st birthday, I did the second best thing I ever did in my life, which was get the implant done. My recuperation went very well. After 2 weeks, everything was basically back to normal. The third week, I was shown how to use it, but I didn't have and start intercourse until the 6th week, just to make sure everything was okay. I did go back to work after 2 weeks, and that was no problem. After 6 weeks, like I said, we started intercourse again, and I went back to working out at the gym. I would work out at the gym and shower with the guys. There were 5 of us that worked out for the last 20 years. And they have absolutely no idea that there's anything in me. Phenomenal. The other things I want to let you know about is my first implant lasted 13 and a half years. And the normal time, I guess people tell you, is 8 to 12 years. So I got a lot more ahead of it than I thought. And at the age of 72, let me see, what am I now, 76? At the age of 73, I had the implant replaced with a new one. So now I've had this thing for almost 17 years. And I will tell you, it has never, ever failed to give me a solid, rigid erection, good for any type of intercourse you want to have. As far as feeling, I find that there's no difference in the actual feeling of the orgasm from before the implant or after the implant. It's exactly the same. Having no prostate, of course, there's no ejaculate, but you still have that feeling of ejaculate being pumped. So that feeling stays. A couple of things I will tell you that people ask me over the time is when you go through the airport and you go through the metal detector, does it go off? The answer is no, it doesn't. My knees go off because I have artificial knees, and they take me over to the side and they take this wand. I don't know if you've ever been wanded at the airport, but they take this wand over your whole body and they go up the inside of your legs and around your crotch and everything else, and it's silent. Nothing beeps or anything. Second thing is, people ask me, well, does it interfere with anything that has to do with urination or with, bladder issues? And the answer is no. I had cystoscopies after I had the implant, no problems whatsoever. The next thing they asked me is, how long can you keep it up? Well, I'm going to tell you, you can be the Energizer Bunny if you want to be. There is no time limit. Now, of course, you're not going to keep it up for that long, but you can keep it up so that, you can provide multiple orgasms. You're lucky enough to have a partner that can have that, and you will stay rigid all the time. The other thing is, as far as taking it down to being flaccid, you can make it as flaccid as you like. And what I mean by that is, if you just push the button and you hold it for 6 seconds, it'll go down to a certain point. If you then just take your hand and squeeze gently on the penis, you can take it down basically same way as if you walked out of a shower on a cold day in Alaska. It can be as flaccid as you like. Simple as that. So it changed my life. It changed my wife's life. One thing we didn't realize is how much intimacy we lost in those 2 years of not having the closeness that we thought that we had. Why? Because I had lost my manhood, and sex wasn't something I wanted to do because I was embarrassed. And so it really changed my life. It saved our marriage. And all I can say is I'm now married 56 years, and these are the best years of my life. I'm 76. If I live another 20 years, I'll have it replaced again. Simple as that. So I definitely recommend it. I'll turn it back to you, Mike. So you have any question? Anybody has any questions for the doctor or myself? That's fine.
Yeah, thank you very much, Cliff. We did have a few pre-submitted questions. I wanted to start with one here. It was related to prostate cancer. So person wrote in saying they had their prostate removed, I assume with a prostatectomy a few years ago in the practice, and they were having a little bit of trouble finding information about, in this case, it was incontinence and ED that they're suffering. So what would you recommend to patients who are suffering these conditions? It's been, I believe he said 9 months since his procedure, and he's not sure where to go, what to do. I think for both of you, speak a good question to answer, giving advice.
Yeah. So, from a Cliff, go ahead. I'm sorry.
That's okay. What I was going to say is the first place to look at is the excuse me, the website that the doc showed you before, edcure.org. That has multiple things about information about erections and about ED. And the other one, if you have incontinence that I know of, is a website called Fix Incontinence, and I think it's .org if I'm correct, right, Mike? Or is it
.com.
.com? Fixincontinence.com, and those are available, and it has loads of material from a patient standpoint of view. If you're looking and wanting to get some answers, Doc, you can have probably some other ones, so I'll turn it over.
No,
to
actually,
you.
those are the main ones that I was going to mention. Actually, those are the ones that I usually send to my patients. And then, yeah, I think it's important, just like we're kind of alluded to, informing yourself with that medication, but also to, talk to potentially the prostatectomist, the person that took the prostate out, because usually when you have erectile dysfunction afterwards, they have some suggestions on who you can go to from an erectile function and incontinence standpoint, because there's oftentimes people like me who specialize in erectile dysfunction treatments as well as incontinence treatments. And so, there's penile rehabilitation protocols that we have that are pretty well studied that we'll try and do after a prostatectomy to try and basically ideally get you back to where you were, or at least close to it, prior to the prostatectomy. The only issue with that is, sometimes because of that, the surgery, like we talked about with those nerves, the erectile function can take a hit because of the nerves not necessarily healing as well after the prostatectomy. And so there are some guys that do regain their function quite quickly and quite well. There's some guys that need some work, and then there's some guys where it doesn't come back, or at least to the point where they're satisfied with their erectile function. So I think it's really important to inform yourself, just like Cliff was saying with the information from the sites, but then B, to go ahead and talk to a professional, talk to an expert as well.
So what's the right timeline if somebody's having a hard time with their prostatectomist getting information, and it's been months or a year since the procedure? When do they seek help from somebody else?
It's a great question. That's usually the point where around a year is when I would definitely start to look into finding an ED expert. I always tell guys, the studies basically show that after a prostatectomy, it can take sometimes even up to a year or so to regain the erectile function, but there's usually some aspect of improvement if you're on some kind of a regimen at around the 6 to 9 month mark. A year would be around the time where I would start to do a little bit of digging and finding someone that deals with erectile dysfunction specifically to try and help with at least coming up with a plan, a protocol moving forward.
Thank you both. Now there's a question.
Real quick,
go ahead.
Oh, go ahead. I think you're talking about the question in the chat.
Yeah, so I think rather than just address shockwave therapy specifically, I think more broadly, there's a lot of, you see Gainswave, shockwave, and a number of other wave-titled therapies. Can you address what those are, if there's a difference between them, if there's a difference in effectiveness, maybe cost, and what people are seeing maybe at a men's health clinic versus what they might see in a urology office?
Absolutely. So yeah, the shockwave therapies are all, the idea of them all is basically to apply ultrasound shockwaves to the penis to be able to try and help break down some of this fibrosis that's occurred on the arteries of the penis, and then ideally to allow those arteries to be able to dilate a little bit better or become a little bit more pliable or elastic to allow more blood flow to be able to come into the penis. In medicine, something that's 10 years old is pretty new. And so, shockwave is around 10 years old. So it's a newer therapy. We're still trying to figure out what kinds of patients it's effective for. Usually it's guys that are having some aspect of success with Cialis, Viagra, the medications, but they're trying to get a little bit more rigidity or a little bit more maintenance in their erections. However, the only issue with shockwave therapy is it's not covered by insurance. And so there's different kinds or different names of them. There's the Gainswave, which is the one that's an at-home version. And there's different types of shockwave therapy, which includes use of a radial transducer versus a linear transducer, basically the type of ultrasound machine that's applying the shocks. The long and short of it is, overall, it depends on who you are and how, where you are on the erectile dysfunction pathway in terms of how severe your erectile dysfunction is as to whether or not that it's going to be effective. And the issue with it not being covered by insurance is that usually you're paying out of pocket for something that can cost quite a bit of money, thousands of dollars for something that may or may not give you a whole lot of improvement. Usually what I tell guys that are interested in the shockwave therapy is that, if you are having some erectile function and some success with the medications, it may be worth doing, meaning it may give you some aspect of improvement. However, it may burn a $5,000 hole in your pocket with no results afterwards. So that's really important to note, that if you're okay with, taking that, financial burden on, then it's a non-invasive, very straightforward way to try and see if you can have improvement, but you may not have improvement. And so, I usually give that caveat when I'm counseling my patients about shockwave therapy, and hopefully that answers that question. And then, really quick, along with that, there's this question about supplements. I mentioned one of them. There's a lot of supplements that are out there. There's this kind of world of non-medical, non-procedural therapies for erectile dysfunction that's big, and there's certain things that can definitely help. A shockwave is one of these things that's creeping in, and we've done quite a bit of research on shockwave, and it is a promising therapy that we just need a little bit more time and research on. There's certain supplements. The one that's the most well-studied that I actually usually recommend to my patients is the one that's called L-citrulline. I can write it down in the chat. But basically the L-citrulline, like I mentioned a little bit during the chat, during the webinar, it increases nitric oxide into the penile, into most of the arteries, but in particular the penile blood vessels. That can help ideally with maintenance, as well as with rigidity in and of itself. That's the most well-studied supplement that we know of that can affect erectile dysfunction. There's erectile function. There's other ones that, ashwagandha is one. Fenugreek seed extract is another one. I don't think there's any issues with either of those. Citrulline is the one that's the most well-studied that I usually recommend. And I've typed that into the chat. Or I think I typed it in. I see it. Hopefully you can see that. If not, let me know. But the other supplements, fenugreek extract and then ashwagandha can help as well. But overall, usually the first thing I'll recommend to patients is the L-citrulline.
Thank you. And there's a question about the penile implants and pain associated with them. So maybe you can address the post-procedural pain, and then Cliff, will you go over your own experience with that as well?
Yeah, I think that was typed before Cliff went into his spiel. I think Cliff did a great job explaining kind of his experience. But yeah, usually it's you have a couple weeks where you've got some soreness. There's an incision on the scrotum. You're taking maybe a little bit of a narcotic medication, plus or minus, ibuprofen and Tylenol plus or minus a narcotic medication. And usually by around the week mark, it's, some discomfort that's ibuprofen and Tylenol are helping out with. And that's usually the extent of the discomfort. And Cliff, I'll let you kind of add to that, or at least elaborate on your experience as well.
Yeah, when I got home from surgery, everything was fine until I took off the bandage and looked at what was there. And I had an older unit than the new units that they use now, the new implants. So there was more swelling with those than there are with the new ones. But basically, I was uncomfortable for a week, but actually, I never took the narcotic. I only took Tylenols, and that really took the edge off everything. Two things I will tell you that will make it a lot easier to withstand the pain, if you want to consider that, is number one, if you sleep on your side, put a pillow between your legs. But if you don't put a pillow between your legs, you will squash your scrotum, and I guarantee you will not sleep. And the second thing is, excuse me, I forgot the second thing I was going to say. Well, that's the most, the second thing is, if you wear boxer shorts prior to the surgery, you should probably wear jockeys while you are healing so that you are cradling the testicles and they are not swinging in the wind. I think that's a very, very important thing to do for at least the time until you feel that there's no more issues of pain or anything like that.
Thank you, Cliff. Now, the only other question I see is about missing the first part of this. So we are recording this webinar, and everyone will receive an email tomorrow with a link to the webinar recording and all the relevant contact information, including a link to Dr. Islam's provider page on the practice website. On that note, what is the best way to get a hold of you, Dr. Islam, if someone wants to contact you after this?
Yeah, so probably the easiest way to get in with me at I know my clinics would be I have a clinic in St. Peter's and a clinic in Fairview Heights, like we talked about. If you go to the Urology of St. Louis website, it's I believe it's just Urology of St. Louis. This is terrible. I should make sure that I know this before I type it in. But if you this is awful. STL Urology, stlurology.com. I couldn't remember if it was Urology STL or STL Urology. And then if you look for, you can go scroll through the urologists that are there, and then basically click on make an appointment or find an appointment, and then make an appointment with me that way. So again, that's stlurology.com, and then you can click on my name and schedule an appointment at any of the offices. And there's also I'll have Mike type the phone number because for whatever reason I'm unable to, but there's also a phone number that you can call to get a hold of our schedulers to get in contact with you as well. And I'll send that number to Mike, and I'll be able to have him place that in the chat. And perfect. And then Mike's be able to get straight to my page there to be able to make an appointment with me. That's probably the easiest way, to be totally honest, is that website there.
Do you want the 9,000 number?
Yeah, I think that one's the easiest. I appreciate it. Yeah, exactly.
Okay. We'll get that up. So any final comments from either you, Dr. Islam, or you, Cliff? Want to tell people who are listening before we conclude tonight's webinar?
Well, I would say basically, it will basically return your manhood to you. And I don't know of anybody who has had one who has not praised and said how much it really has changed their lives for the better. And that's reflected in the percentage of men who have had them and in their partners. 96% of all partners say it's great. So, and it's the most natural one and natural thing you can have. So I highly recommend it.
Yeah, and then to echo that a little bit, in general, I think the implant is a fantastic option. Most of the guys that go through that are quite happy with the results. But more importantly, I think from an erectile dysfunction standpoint, it's really important to it's kind of like Cliff did. Go out there and find someone that's an expert and find someone that's willing to take you through the steps and take you through, the options of dealing with the erectile dysfunction, not only for yourself, but also for your relationship, for your partner, and for your own, mental and physical well-being in terms of getting the erectile dysfunction figured out, but also, again, to make sure that whatever the etiology may be, to getting that treated as well. And so, we're here, we're happy to help, we're happy to be a resource, but also, kind of taking your quality and quantity of life into your own hands is important.
I want to thank you both for your time and all the information you shared tonight, and everyone for attending. Again, you will receive an email tomorrow with that phone number, the website, and a link to the webinar recording. Thank you all again. Have a wonderful evening. This concludes tonight's event.
Good night.
Take care. Have a good night.